this was just 10 to 15 minutes. What can I do in this lecture? So I want to concentrate on important in practice. You know, musculoskeletal infection, it is usually present in the board exam, especially in the oral and as a lone case. So today I will focus in many things respect to this topic. The objective of this topic is to know the most common musculoskeletal infection, pediatric, and how to approach in a proper sequence manner. The second is to know the complication and sequelae of missed and untreated infection cases. First, we will start with osteomyelitis as definition and epidemiology, pathophysiology, most common site, why, risk factor, most common positive organism, diagnosis, management, complication. Start with definition. You know, it is an infection of bone and bone marrow. Incidence is 1 in 5,000 children younger than 13 years old. Demographic, mean age about 6.6 years. 2.5 times more common in boys. More common in the first decade of life due to rich metaphysical blood supply and immature immune system. Not uncommon in healthy children. The pathophysiology, always we have a common question about the pathophysiology of the osteomyelitis. We can classify it as microscopic and macroscopic changes in the osteomyelitis. You know, it is most common in the metaphyseal area. Why it is metaphyseal area? Because it is rich blood supply. The second is the configuration of the arterial blood supply. It is sharp end of the arterial blood supply. This is make the flow of the blood is slow, so it is more time to lodge of the bacteria in the sinusoid and that side. The second thing is the low pH and decreased autotension in that side around the physis. So it is make a suitable area to start the infection. That's why. The second thing is a weak immune system on that side. You know, so in the microscopic changes, there is a lodging of the bacteria, start of the infection by osteoclastic decreased function and increased function of osteoclast. So there is a debris of bone, necrotic bone. This is accumulation and make a pus, okay? After that, there is a spreading of the infection through the cortex, subperiosteal elevation. Sometimes the necrotic bone make, which is called sequestrum, okay? And around that, there is a new bone formation called the umbilicum, okay? So you have to know the pathophysiology of the osteomyelitis in this way. Risk factor, most common risk factor is the trauma. It consists about 30%. Diabetes mellitus, hemoglobinopathy, juvenile rheumatoid arthritis, chronic renal disease, immunocompromised, varicella infection. Most common organism is the Staph aureus. Why the Staph aureus is most common organism in the infection of the bone? You know, there is called osteoclast internalization because the Staph aureus has a dendritic receptors that can be lodged inside the osteoblast. You know, the osteoblast is the common cells in the bone. In recent years, there is some strain of Staph aureus. It is a PBL positive strain of MRSA. It is associated with complex infection, more complication, multifocal infection, DVT. Group B, Streptococcus is most common organism in neonate. Genicilla becoming more common in younger age group. Pseudomonas associated with direct puncture wound to the foot. Influenza has become much less common with advent of Haemophilus influenza vaccine. Mycobacterium tuberculosis, children are more likely to have extrapulmonary involvement. Biopsy with the stain and culture of acid fast bacilli is diagnostic. Salmonella, more common in sickle cell patient. And fungal osteoarticular infection are due to Aspergillus and Candida species. Diagnosis, we start with history, clinical exam, and lab and imaging. In history, it is according to the age. You know, in pediatric, we have a diversity of the age, start from neonate, child, toddler, and after that, the young, near to the maturity. So in neonate, usually the patient, patient come with pseudoparalysis and paradoxical movement. In more older, in young children, there is a limb pain, recent local, there is a decrease in range of motion, inability to bear weight. In older children, start complaining, localized pain, limb pain, and has restricted range of motion and has systemic manifestation. So the most common symptoms is limb refusal to bear weight, generally in osteomyelitis, not toxic, appearing like septic joint, and maybe associated with fever or not. In physical exam, we have edematous, warm, swollen, tender limb, evaluate for point tenderness in pelvis, spine, or limb. Usually, we differentiated the osteomyelitis from other differential causes like cellulitis by percussion test. We make a percussion far away from the site of the complaint. If the percussion test is positive, eliciting the pain, this means that there is infection in the bone. While in the cellulitis, which means soft tissue infection, there is negative percussion test. Range of motion, there is restricted motion due to pain. Diagnosis, imaging, we start with radiograph, simple. We obtain AP and lateral of the suspected area, usually in early pain, maybe normal, or show loss of soft tissue planes and soft tissue edema. There is new periosteal formation 5 to 7 days, osteolysis in 10 to 13 days. In late film, maybe show metaphyseal refraction, reduction in metaphyseal bone density, or possible access. In chronic osteomyelitis, sometimes there is a sign called Codman triangle. You know, this question usually asked in the board. So the differential diagnosis of Codman triangle, sarcoma, osteosarcoma, or subperiosteal abscess.
5 minutes.
Okay. CT to assess bone status, cortical destruction sequestrum. MRI, it has high specificity and specificity, especially if associated with gadolinium contrast. There is a decrease in T1, increased enhancement in T2. Bone scan has sensitivity 92%, and usually used to rule out multifocal infection, or in young children has dead history. Serum lab, we start with white PC count, elevated just in 25% of the patient. C-reactive protein has a high sensitivity, 98 is reached about 98%, and it is a good parameters to monitor for response for management. ESR elevated in 90% of the osteomyelitis, usually not less reliable in neonate and sickle cell patient. Also, there is a new serum lab called plasma procalcitonin, elevated in 58 and high sensitivity in the bacterial infection. Bone aspiration help in establish definitive diagnosis, sensitivity about 50 to 70%. Blood culture positive only in 30 to 50% of the time, likely to be negative soon after antibiotics are administered. This is common problem we face it in the clinic. The patient usually goes to the pediatrician, he starts the antibiotic, and then after that he came to us. If you can do, if you wanted to do an aspiration and you can't find, especially in the septic joint, and you can't find a fluid, you can inject 3 to 5 millimeter sterile saline and then re-aspiration. Complication of osteomyelitis, DVT, risk factor, CRP more than 8, surgical treatment, age more than 8 years, MRSA, meningitis, septic arthritis, especially in neonate patient, and bones with intra-articular metaphyseal, we know shoulder, elbow, hip, and ankle. Knees not included. Growth disturbance and limb link discrepancy, pathological fracture. This is some cases we face it. This is a patient 13 years, present to the ER after trauma. You can see normal X-ray. 4 days later, the patient again came to ER with severe arm, shoulder pain, fever, and restricted range of motion. Lab was YPC's 33,000, CRP positive, ESR 90. So it's been an infectious insult. What is your next order? We do MRI. Next MRI. لا بحاله زي هيك انت ريست يعني 4 days في بين كذا MRI is the gold standard. هلا اذا كان في عندك سبري اوستيال احنا حكينا البروسيس الميكروسكوبيك والماكروسكوبيك تيصير عندك سبري اوستيال abscess formation, it takes a longer time. Okay. After you found the diagnosis, نعمل له debridement, we inserted cement beads with the antibiotics. كان sensitive على vancomycin. هلا keep the antibiotic. هلا بالنسبة للantibiotic, usually the examiner asks which antibiotic you start. Empirical antibiotic, usually with consultation with infectious disease specialist. Okay. Another case. This is a later presentation in the shaft of the radius. You can see there's a destructed bone. This is the previous X-ray, just few months before that. So you can imagine the disaster consequence of the osteomyelitis. MRI was done. We did here, which is called Musculi technique. You have to be familiar with this technique. Same presentation in the tibia. Septic arthritis, you know, it is an infection in the synovial membrane in the joint. Now, in a scenario, can 2 months old female patient, preterm, history of an ICU admission, post delivery for 1 month, 1 week history of irritability and painful process of change labor, and 1 day history of fever. What's the risk factor? You can, the age, preterm, an ICU admission, you know, there's umbilical catheterization. The sequence of events done for this patient, we did an X-ray, ultrasound, and lab. The YPCs was 19,000, ESR high, CRP high, ultrasound show hip effusion. We know the Kocher criteria, which is 4, YPCs more than 12,000, inability to bear weight, fever more than 38.5, ESR more than 40. Sensitivity, one of them, it is 3, 2, 33, 3, 93, and the fourth is 98. Modified criteria added the CRP. هلا بنعمل لها incision drainage, can turbid like fluid and aspiration under CRs. The most common organism according to the age, neonate Streptococcus pneumoniae, as we mentioned before, the infant Staphylococcus aureus, with adolescent Staphylococcus aureus, with adult also Staph aureus, with IV drug abuser, suspected Pseudomonas, and atypical organism. You can see here in the X-ray, there is a left subluxation and dislocation of the hip, okay, due to fusion. This is the sequelae. Differential diagnosis of the irritable hip you have to be familiar with. Take-home message: pediatric osteomyelitis septic arthritis are one most common condition that will encounter in your career as orthopedic surgeon and pediatrician. You have to know the algorithm of sequence of physical, radiological, lab investigation, and surgical treatment. Surgical treatment of friction, consider major surgery that must be done with well-trained, experienced surgeon. So don't hesitate to join your senior to learn and get experience in how to deal with these cases. Keep the threshold for septic arthritis diagnosis very low to avoid irreversible, devastating complication of this case. Thank you. Good luck.